Today, we are going to be talking about mental health disorders throughout the lifespan, starting with child and adolescents and working our way through older adults. When we talk about mental illness in children, it can often be very difficult to diagnose. This is because a lot of behaviors that are considered symptoms of mental illness are actually normal for children. So, for example, having an imaginary friend could be similar to hallucination, but it's very common as children grow and develop their creativity. Other things like having fantasy play, superstitions, things like that can be similar to what we see in OCD, psychosis, and bipolar disorder. So, a lot of times it's very difficult to understand if it's just normal childhood development or a mental illness. We do know that mental illness in children is more common in unstable households, in those that are in and out of the foster care system, those that have experienced child abuse, those that have been adopted from other countries, having a hard transition as they come to the United States, having an abusive or neglective caretaker, or in children that travel a lot. Um, Other aspects of mental illness in children that we don't always think about is having a neurodevelopmental delay is considered a mental illness. So, this could be a delay in development of attention, cognition, language, affect, and social or moral behaviors that's outside of the cultural norms of that child. Oftentimes, neurodevelopmental delays are manifested in delayed socialization, poor communication skills, peculiar mannerisms, and idiosyncratic interest. When we talk about mental illness in children and how to properly treat it, it can be a very difficult approach. A lot of times we try to use medications less and rely more heavily on things like therapy. We do know that um, when we look at the different disorders in children, the prognosis can be much greater for some illnesses like childhood bipolar disorder or childhood schizophrenia, but it can also be less severe of a prognosis when we look at other disorders such as anxiety or depression that some children are able to grow out of. We also really rely heavily on behavioral modification, which, like I said, that can be done through the therapy and through different types of um, alternative therapies. Another thing that we want to talk about is hospitalization of children with a mental illness. There is some controversy over whether or not inpatient hospitalization is appropriate for children, as this can take them away from school and proper socialization. Um, and it can delay their success in school and delay their success in forming proper social behaviors. Also, we see this sometimes, not often, but occasionally a parent will admit their child to the psychiatric hospital, not because they actually need inpatient treatment, but because the parents need a break from that child or are looking for different housing situations for that child. And in a lot of ways, this can be very traumatic for the child, and it can be um, often unfair to have them hospitalized for that matter. So, one aspect of mental illness in children is delayed intellectual disabilities. So, when we talk about an intellectual disability, this is a limitation in intellectual function and in adaptive behaviors that cover everyday social and practical skills. In order to be diagnosed with an intellectual disability, they're often diagnosed before the age of 18. They also have to have impaired adaptive functioning and judgment, and it can interfere with their ability to perform ADLs. This can be based on IQ testing. There's a lot of different IQ scales, but typically we'll use the Stanford Binet or the Welcher Intelligence Scale. And in order to be diagnosed with a cognitive disability, they would have an IQ test of 70 or less. Having an intellectual disability can increase the child's chance of having a mental disorder by 3 to 7 times. This can be due to stress, bullying, and lack of social support, but it can also be due to biological changes. And we see this in different things like autism and schizophrenia. A lot of times, mental illness or intellectual disabilities in children are caused by a chromosomal change or a chromosomal defect. And it can also be caused from exposure to toxins prenatally or through different illnesses that the mom can develop or complications that the mom can develop prenatally. When we look at the nursing care for someone with an intellectual disability, our assessment skills are going to include how well they are able to use their adaptive skills. How do they change when their schedule or their structure is interrupted? How well can they perform ADLs? We're also going to look at their intelligence, including their judgment, insight, and reasoning. We're going to assess their social functioning. Are they isolative, aggressive, appropriate in their social interactions, interested in social interactions? We're going to assess for any comorbid illnesses, both medically as well as psychologically. And then we're going to assess the child's behavior, both at home, in school, and in other areas of their life. As far as treatment goes, safety is priority. So we're going to address any unsafe behaviors or environments to that patient. And this can include addressing any medical concerns that may lead to safety implications. So, for example, some intellectual disabilities have comorbid breathing or cardiac conditions. So, we would want to prioritize that to make sure that they're having proper respirations and proper circulation. Um, we would also want to create a behavior plan and find ways to increase their confidence in quality of social interactions. And then we can address any needs specific to that patient. So, do they have any home care needs that are required? Do they need any special accommodations at school or in the workplace? Do they need accommodations to engage in leisure activities? Overall, our goal is to provide optimal functioning for both the child and the family and any caregivers they have so that they can function within a normal social environment as independently as possible. So, the next type of disorders that I want to speak about are the autism spectrum disorders. These are a form of neurodevelopmental disorders that occur on a spectrum with varying severity of symptoms and interruption of functioning. When we look at autism spectrum disorders, typical characteristics of it are defects in social communication and social interactions. And this isn't due to a lack of illness. A lot of times, children with autism are very interested in having social interactions and social relationships, but they don't necessarily have the confidence or social skills um, that you would see in a child without autism. So it can impair their ability to communicate and interact with others. We can also see restricted or repetitive behaviors, as well as interests that can interfere with their social, physical, and other forms of functioning. As I kind of mentioned already, children with autism can be isolative. They may avoid affection or engaging in behaviors that limit that social communication and bonding. But like I said, they still have that strong desire for sameness with their peers and for social interactions. Sometimes we see echolalia as well as echopraxia with autism spectrum disorders. So, if you remember back in our discussion on the mental status exam, echolalia is the repetition of words or phrases that may be made by others, where echopraxia is the repetitive movements. In children, this can be frustrating to the child's peers or those within the social group. So it can impair their ability to have acceptance as well as social interaction. So we would want to assess for any reaction that others have to the child's behaviors. Other things that we can see with autism spectrum disorders are varied patterns of intelligence and intellectual strengths and weaknesses. So, some individuals with autism spectrum disorders have superior intelligence and are of genius status. They may have excessive knowledge or competency in specific categories of knowledge as well as general knowledge. And then we can also see children with autism that have that IQ of less than 70, where they're considered to have an intellectual disability with it. As far as the behaviors go that we see, we have that stereotypical behavior. So, like I mentioned, the echolalia, the echopraxia, but we can also see repetitive body movements and repetitive movements of objects, rocking, hand clapping or waving, as well as repetitive non functional movements. We can also see things like emotional outburst, especially when the child is faced with an overstimulating environment or when they're in situations that they are unable to communicate what they're feeling. During these times, we would want to assess the patients to make sure that They're not becoming overly aggressive or assaultive towards themselves or others. And with that, we can see self injurious behaviors with autism spectrum disorders. This commonly includes hitting themselves, banging their head on objects such as the wall or a desk or things like that, as well as biting themselves. Lastly, we can see fascinations, and these are obsessions with a particular object, topic, or place. Individuals with autism spectrum disorders also have difficulty processing sensory input. So sometimes they are overstimulated as far as their sensations go, or they may have a lack of sensory stimulation, and that can lead to some of these behaviors. Lastly, with the autism spectrum disorders, we would want to have assessment of their response to change. A lot of times, individuals with autism spectrum disorders have difficulty with change, and they tend to really thrive in like a rigid and consistent schedule. As far as the epidemiology goes, we do see this more commonly with the male gender. About half of individuals with autism spectrum disorders have intellectual impairments. About one fourth of individuals with autism spectrum disorders have seizure disorders. There is a very close link between autism spectrum disorders and schizophrenia, and there's a lot of debate as to whether or not individuals diagnosed with autism actually have schizophrenia, or is schizophrenia underdiagnosed in children with autism, because a lot of times the symptoms are very similar and present very similarly in child schizophrenia as well as autism. Some expected or suspected causes of autism are exposure to lead, mercury, or lower level of antioxidants as a child. It may also be correlated with byproducts of gut bacteria. It can be related to maternal autoantibodies that accumulate in the brain as the fetus starts to grow and develop. It can also have a strong genetic link between development of autism spectrum disorders. And I do want to make a point that there really is no evidence that vaccines cause autism spectrum disorders, which is a common misconception when people talk about autism. So when we look at the specific spectrum disorders and specific spectrum diagnoses, we see things like Asperger's disorder. So with Asperger's disorder, the child may have limited or inappropriate social interactions. Their conversations tend to focus on themselves rather than others, and they may be prone to have one-sided conversations where they have an inability to reciprocate conversations. They may lack eye contact and have robotic or repetitive speech patterns. They may have awkward movements or mannerisms. They may have challenges with reading and perceiving nonverbal communication, but they typically do okay with verbal communication. They may have difficulty understanding social or emotional cues as well as non-literal phrases. A lot of times with Asperger's disorders, we do see obsessions with specific topics that are often unusual, and these individuals are often very, very intelligent in that specific topic. Individuals with Asperger's are often very high functioning individuals and are still often thriving in the workplace, in the school setting, in the family setting, and do quite well. And they also tend to have not as many outbursts as some of the other autism spectrum disorders. Another form of autism spectrum disorder is the childhood disintegrative disorder. And this is a pervasive developmental disorder that affects many aspects of the child's life. And what we see is they typically have normal develop, but then they tend to digress in development of socialization, communication, and motor skills. Another form is Retts disorder. This is an X-linked genetic mutation that causes the autism spectrum disorder. And typically, these children will lose the ability to verbally communicate. They may lose hand control and develop hand tics. It's often accompanied with respiratory, GI, and muscle movement disorders. And then another one is the pervasive developmental disorder. And this is when the child has dysfunctional speech, inability to play per their developmental level, and social impairments that develop around the age of 3. They can also have social impairments, but it's often not severe enough to be considered typical autism. They generally are higher functioning because they do well with that social skills. Then we have just the generic assessments and interventions for autism spectrum disorders. And again, the assessments and the interventions are going to vary due to the severity and the form of autism spectrum disorder that the child's diagnosed with. So, as far as assessment goes, we would want to assess for any of those comorbid disorders, especially seizure disorders, depression, other childhood illnesses that may impact their ability to function socially as well as their physical health. We would want to assess their coordination, their risk or history of injury and self harm. We would want to assess their intellectual and language impairments. We would want to assess their sleep, appetite, and activity patterns, assess for any stereotypical behaviors, their communication abilities, any fixations or interests in particular topics, what their triggers are for any agitation or self harm, what their response is to changes in their typical schedule, what their typical schedule is. We would want to assess their daily routine. We would want to assess things like how their home structure is set up, because if our child is brought into an inpatient setting, we would want to try and set up their hospital room as close and familiar to their room at home as possible to keep that consistency in environment and schedule. We would also want to assess what calms the patient down or helps them transition when there are schedule changes or environment changes. We'd want to assess the family functioning and any special accommodations that are needed while the patient's in the hospital or in the school setting or in the home setting, or to engage in any activities. As far as intervention goes, education is going to be important. We would want to help teach these children self care skills and how to adjust to schedule changes. We're going to monitor safety for both the patient as well as the staff. And this includes ensuring that they maintain that structured stability and predictable environment. As far as medications go, we may prescribe things like antipsychotics or anti anxiety medications to help with some of the outbursts or self harming behaviors. We would want to do things that promote social interaction. So, for example, getting the mail while the mailman or mail woman's delivering the mail so that they have that social engagement with others. We may have them pass out snacks in the classroom so that they get the opportunity to interact with their peers. We may assign them to certain tasks at home or in the school environment where they pair up with someone else so that they have, again, that opportunity for social interaction. As far as schedule changes go, we can use visual cues or auditory cues to designate the start and end of activities so that if we have to change the time of activities, we have that visual cue that kind of helps them with that transition and knowing what to expect. We can also reward good management of transitions. And like I mentioned earlier, we can keep objects in the same place or include familiar objects around to provide comfort for that patient. As far as behavioral modifications go, if they're engaging in a negative behavior that's not causing harm to themselves, the best thing to do is ignore that behavior and eventually they'll stop it. If they're engaging in a behavior where they are harming themselves or others, then we can redirect the patient and offer positive reinforcement when they have good responses to that. Or if necessary, we can use proper holding techniques to protect that patient and the safety of others. As far as family support goes, we really want to be able to allow the family to express any denial, frustration, grief, guilt, anger, or disappointment that they have. There's plenty of support groups as well as respite care that we can provide for the family. We would also make sure to provide support and education to the family member. And we really find it necessary that family and caretakers assist with the treatment plan and the care plan so that we know what's best for that individual patient. As far as therapy goes, there's a lot of different forms of therapy for autism spectrum disorders. and one of them is autism behavioral therapy. And this is specific for individuals with autism spectrum disorders, and it helps them build their social skills as well as daily activities. Um, so that's about it for autism spectrum disorders. So now moving on to attention deficit and attention deficit hyperactivity disorders. These are the most commonly diagnosed mental disorders in children, and it typically is diagnosed before the age of 12. It has components of inattention, hyperactivity, and impulsivity that can impair with this child's functioning. So they have difficulty filtering incoming information and screening through what's important. This inability to filter through that can cause a lot of overwhelming behaviors as well as energy that can lead to risky behaviors. We do find that attention deficit hyperactivity disorder is commonly comorbid with conduct disorder, which we talked about when we talked about personality disorders. So the DSM-5 criteria for the diagnosis of attention deficit hyperactivity disorder, or ADHD, is that they have to have at least 6 of the 9 symptoms of inattention, as well as at least 6 of the 9 symptoms of impulsivity. So the symptoms for inattention are failure to pay close attention to details, difficulty sustaining attention. The child may not appear to be listening when spoken to. They might not follow through with instructions and have difficulty organizing tasks. They may avoid or dislike tasks that take sustained mental effort. They often lose things and can be easily distracted by extraneous stimuli, and they may be forgetful of completing daily activities. The symptoms of impulsivity is fidgeting, leaving their seat when they're expected to sit, running or climbing in inappropriate settings, being unable to play or engage in quiet activities. They may be described as often being on the go. They can talk excessively. They often blurt out answers before they're called on. They have difficulty waiting their turn, and they can interrupt and intrude others. The belief as to why ADHD develops is there tends to be a strong genetic component, so it does run in the family. It's also common in families that have a history of bipolar disorder, substance abuse disorders, prenatal tobacco use or pesticide exposure prenatally, or lead exposure in early childhood, which can increase their chances of developing ADHD. Males are 2 times more likely to be diagnosed. They often have excessive hypersensitivity to environmental stimuli. We do find that development of ADHD may be related to allergies, especially allergies to dyes or artificial flavoring. It can develop from frontal lobe connections to subcortical structures that are dysregulated. It can also be caused by dysfunction of the dorsolateral prefrontal cortex, which is responsible for managing our emotions, reactions, and directed attention. We do find that ADHD is higher in families with significant stress, marital discord, crowded living conditions, poverty, and parental substance abuse. So, when caring for someone with ADHD, some nursing considerations is monitoring the family response, especially when the family response is maladaptive. We want to educate family to increase structure of the environment and to collaborate closely with schools. We want to educate family to resist any emotional overreactions to the child's behavior. We want to help them focus on the child and provide consistency and discipline, as well as to keep track of activities and schedules. As far as conduct problems go, we want to reinforce any good behaviors and punish poor behaviors. We want to address any depression that may develop or the need for psychiatric inpatient admissions for excessive hyperactivity that can lead to dangerous behaviors for that child. And we also want to be aware that sometimes the conduct problems can lead to involvement with the law, economic problems, substance use, and other risky behaviors. Early treatment of ADHD can include medications as well as a behavioral approach. So we would want to do symptom management and education. As far as medications go, we often use stimulants, and these stimulants can be addictive and they have a high potential for abuse. It can also suppress a child's appetite. So, if they are on a stimulant, we would want to make sure we're assessing their nutrition to make sure that their nutrition is balanced and that they're not having excessive weight loss. Another thing to think about is sometimes these children will sell the medications to others that want it either for weight loss or for improved focus. And if they are selling their or giving away those medications, they're not taking it themselves. So they may have poorly managed symptoms. As far as safety issues go, we would want to assess for any risk taking behaviors. And we also want to be aware that they have an increased risk for depression and suicidal behaviors. For school performance, we want to be aware that it can be poor due to their hyperactive behaviors. So they may have behavioral problems as well as difficulty in learning in the school setting. And when we do assess our patients that have ADHD, we want our interviews to be brief because they have a decreased attention span. So they tend to thrive more in environments where they're getting shorter lessons rather than longer lectures. Um, as far as school performance goes as well, their hyperactive behaviors can often be seen as disruptive towards other children. And it can also increase impulsivity, which may increase the risk of getting into arguments or fights in the school setting. So, when we're assessing our patients with ADHD, we want to assess a physical assessment and look at things like their sleep patterns. They may have restlessness due to fidgeting, and if they're taking their stimulant medication too late in the day, it can interfere with their sleep problems. We would want to assess their eating habits, like I mentioned, especially when they're taking a stimulant. If they are taking a stimulant, we would want them to avoid caffeine because that can lead to cardiac problems. If they are not prescribed a stimulant, however, drinking a cup of coffee can be very effective in helping that child to focus. We would also want to assess any patterns of activity. We would want to assess their medications and any side effects, as well as any allergies. We would want to assess any triggers for inattention or hyperactivity, as well as any focus measures that are tried. We would want to assess their school performance. So, are they having difficulty focusing? Are they having difficulty making decisions? How is their interaction with their peers? How's their family interactions? Are the parents frustrated or exhausted? And is that showing towards the child? Is the child annoying their siblings or their parents with their disruptive behaviors and intrusiveness? And how does the family respond to that? We would want to assess their cognitive process. How's their focus? Are they having those symptoms of depression? Um, and then as far as interventions go, like I said, we can provide a psychostimulant. The way that these psychostimulants work is they enhance dopamine and norepinephrine activity to help improve attention and focus. It can increase their inhibition, so use of psychostimulants can prevent impulsiveness. And how it works is it allows the individual to better screen any external stimuli. Usually, it's given on a schedule that best allows the child to focus and learn in school. So, we would give it when the peak effectiveness is during that school time. And, like I mentioned earlier, we really would not want to provide any medication too close to bedtime because that can cause them to stay awake. So, examples of psychostimulants are Ritalin, Concerta, Metadata, and Adderall. For patients that don't want stimulants for the addictive qualities or the effect that it may have on their nutrition, we can provide them with Strattera, which is a non adrenergic reuptake inhibitor. This is typically something that can treat anxiety, but we do find that it has good benefit towards treating inattention as well. Side effects for Strattera are headaches, stomach pain, decreased appetite, vomiting, somnolence, and nausea. Another medication that we can use is Intuniv. As far as treating any behavior modifications go, we would want to use a positive behavior reward system. We can do education and training for the parents on how to best support the child in school as well as socialization. It's important to have good structure, so setting clear limits and consequences. establishing and maintaining a predictable environment, having a calm environment with limited stimuli, using eye contact when giving instructions and have the child repeat those instructions to ensure that they were able to understand them. We would want to encourage doing homework one assignment at a time and in a quiet environment with frequent breaks. As far as sleep promotion goes, if they do have difficulty sleeping on stimulants, we can provide them with Strattera, which has that less stimulating effect. We would want the patient to keep a sleep diary, and we'd also want to teach sleep hygiene techniques. As far as nutrition changes go, if we suspect that the ADHD reaction is due to an allergy to food, we could put them on the Feingold diet, which is a restriction elimination diet. So basically, what it does is you eliminate all foods and then slowly enter a food one at a time every couple of days to see if it has an impact on their hyperactivity and inattention. It's also removing um, any chemical based or non organic foods. So the child is eating all natural and chemical free foods. Like I said, we would want to remove caffeine or other stimulating substances if they are on a stimulant, and we would want to monitor for any weight gain or loss. Generally, if we're starting a patient on medications, the results are seen within 1 to 2 weeks. And a lot of times, if they do require psychiatric treatments for ADHD, it can be done outpatient. Other childhood mental disorders that we can see are related to learning disorders. So, with our learning disorders, there's a discrepancy between actual achievement and expected achievement academically based on the person's age and intellectual ability. This is not considered a result of poor intelligence or poor education, and it can be categorized as a verbal learning disorder or a nonverbal learning disorder. A lot of times we see the nonverbal learning disorders with ADHD, and this is things like dyslexia, where the children may have difficulty organizing words and sentences, or it could be where they have difficulty with numbers and difficulty with mathematics. A lot of times there is a family component with these nonverbal learning disorders. The other forms are phonetic processing disorders, and this is when they have poor discrimination and interruption of speech sounds. So, this is often a result of dysfunction in the left hemisphere. Then we have our communication disorders. So, these are speech or language impairments. They are more common in children that have ADHD, autism, anxiety, and conduct disorders. It could be where the speech is impaired due to a motor impairment, such as with stuttering, or it could be an impairment due to language processing. So they may have a hard time putting sounds together for meaning. A lot of times, if a child has a communication disorder, they'll work with a speech and language pathologist or a school nurse to help build better communication skills or improved communication skills. Having a communication disorder can negatively affect the child's ability to socialize and learn. So they may be isolative. They may also feel insecure or embarrassed by their speech and communication disorder, and they may have poor ability to share and cooperate. So, when treating a communication disorder, we not only want to try and improve the communication as best that we can, but we also want to help the child to build confidence and help them find the resources that they need. Then we have our tic disorders. There's both motor as well as phonic tics. So the motor tics can be quick, jerky movements of the eyes, the face, the neck, or the shoulder, whereas the phonic tics are repetitive sounds such as throat clearing, grunting, or use of more complex sounds like using words or phrases. Typically, a tic disorder will resolve on its own, but it is highly correlated with obsessive compulsive disorder as well as ADHD. Having a tic disorder can lead to behavioral problems, poor impulse control, low self esteem, and other things. The most common tic disorder that we hear about is Tourette's disorder. So, this involves both multiple motor as well as phonic tics over the span of at least 1 year. And when we're assessing our patients with a tic disorder or with Tourette's, we would want to assess the type of tics and if there's any triggers and how long the tics last. Typically, the onset of Tourette syndrome is about the age of 7. The symptoms wax and wane. They're generally non progressive and they tend to diminish in adulthood. It affects boys more than girls by about 3 to 6 times. It may be due to dysregulation of the corticostriatal thalamic circuitry. It can also be caused by irregular dopamine systems, which includes noradrenaline, endogenous opioids, or serotonin regulation. And it can also be related to genetics. When we have a kid with a tic disorder, we would want to assess the family response. So, how do they perceive those tics? Do they believe that the tics are intentional or deliberate to annoy them, or do they understand that it's outside of that patient's control? We would want to educate the family on the involuntary nature of the tic, as well as how to accommodate so that the child can still have a high functioning lifestyle when experiencing frequent tics. In addition to what we already talked about with the assessments, we would also want to assess their self esteem. The child may be embarrassed or withdraw socially, and as well as they may be bullied or picked on by others. So we would want to assess for that. As far as accommodations for those that have difficulty with socialization, it's important that we educate their teachers to help the child feel welcomed in the environment. So some techniques that you can do is educate the other children on what a tic disorder is and educate them that um, it's outside of this individual's control. Other techniques that people have used is they'll let each child pick a sound so that when the child with Tourette syndrome has a tic and starts making movements or noises, everyone else can say their sound as well. So it helps that child to feel more inclusive and it helps the other kids to understand the tic a little bit more. You can also have the child run an errand when they start having experience of the tics to help protect them from any bullying or poor response by other children. And then we have our separation anxiety disorders. So the DSM-5 diagnosis for separation anxiety disorder is that the child has normal separation anxiety that diminishes between the ages of 3 and 5, but with separation anxiety disorder, that anxiety that they experience persists beyond those ages. Um, some typical symptoms that we see with separation anxiety disorder is that the child may cry or hide from their parents when separation is anticipated. They may refuse to go to school and develop school phobia. They may throw temper tantrums when separated from a family member. And then they may be mad at that family member and ignore them once they return. This is a very common mental disorder in and adolescents. The high level of anxiety that they experience can interfere with daily functioning. The theory as to why it develops is they may have insecure attachments early on. It can be related to their temperament. It can be related to genetics or any family member changes. So, this may include the birth of a new baby, possibly grandparents moving in or other family members moving in, as well as death or separation of family members. As far as interventions go, we would provide therapy and education for both the child and parent, and this could include cognitive behavioral therapy as well as school consultations. And then we can also provide them with a selective serotonin reuptake inhibitor. Then we have obsessive compulsive disorder. We have talked about this in the adult population, but it can occur in the child population as well. It's often very difficult to assess in children due to the typical ritualistic behaviors that I talked about earlier. So it's not uncommon for children to not want to step on a crack for fear that they'll break their mother's back, or to engage in activities where they want to touch everything. So it's very hard to differentiate between obsessive compulsive behaviors and typical child development. We do find that if OCD is diagnosed in childhood, their obsessive thoughts are often related to fear of catastrophes occurring towards their family, contamination of germs, sexual or somatic obsessions, or overly moralistic thoughts. The etiology and assessment is very similar to what we see in adults, except with the assessments, you would also want to assess how it contributes to their functioning and socialization at school. Common compulsions that we see are washing, checking on things, repeating things, and ordering things. In order to be diagnosed with this, the compulsions have to waste time, cause distress, and interfere with their daily life. As far as interventions go, we're going to use the same treatments that we use in adulthood, including cognitive behavioral therapy, cognitive training, and exposure therapy. The one exception is we do try to use medications less in child than we would in the adult population. And if we do prescribe them with medications, it'll often be at a lower dose than what we see in adults. And then we have our elimination disorders, enuresis as well as encopresis. So, enuresis is involuntary urine secretion beyond the age that bladder control should be present. When it's nocturnal, it means it happens at night, and when it's diurnal uresis, it happens during the daytime. This is more common in young boys, in children that are sexually abused. When we have a child that has enuresis, we're going to assess for the frequency and duration of incontinence, any emotional problems, the family's attitude to the incontinence, if they have any UTI or bladder infections, what their typical toileting habits are, how their family home environment is, if they've experienced any abuse or if there's any new family members. So we do find that a lot of times when parents have another child, the older child may have some regression and they can develop enuresis and encopresis as well. As far as treatment goes, we can use desmopressin or DDVAP. This is an antidiuretic hormone that limits urine production, so they have less episodes of incontinence. We would want to help regulate their toileting habits, so we could regulate when fluids are consumed. So if they have frequent urination and incontinence while sleeping, we would want to make sure that we're not giving them too much fluids too close to when they're going to bed. We would also want to make sure that we're treating any constipation because that can lead to incontinence of urine as well. We can also use the bell and pad conditioning. So this is when the child will sleep on a alarm that senses any moisture. And what happens is as it senses the moisture, it sets off a bell or some type of alarm that alerts that child to either wake up or to go to the bathroom to complete any urination so that they don't have incontinence. We would want to assess and treat any social issues or any way that it can impair their school functioning or interrupt their school functioning if they're wetting themselves at school. Encopresis similarly is incontinence, but it's incontinence of urine, or incontinence of stool. So this is when they soil themselves of feces or they deposit feces in inappropriate places. This is diagnosed after the age of 4, and it has to occur at least once per month. The most common cause of encopresis is fecal impaction with leakage around that. So the child loses the urge to defecate, and they may not feel a leak. Oftentimes, their nose may become immune to the smell of stool, or they may have poor sensation of smell, so they may not realize that they've become incontinent. This is more common in males, and it can very significantly affect their school and social functioning. So, treatment for encopresis is to address any medical causes of the incontinence of stool, exercises to strengthen their anal muscles. We can use bowel catharsis followed by mineral oils, so making sure that they don't have any impaction. We can also have them eat a high fiber diet, and we would want to regulate their eating schedule and allow time for defecation. So we would want them to sit on the toilet for a predetermined time after every meal. Then we have our mood disorders. So, with the mood disorders, a child can have both depression as well as mania and bipolar disorder. Depression is much more common than mania. However, bipolar is possible in children. When we look at mood disorders in childhood, we would want to make sure we're assessing any behavioral issues. That's going to be our biggest concern, especially by behavioral issues that impair safety. As far as interventions go, we're going to approach it similarly to how we would approach it in adulthood. And we would want to focus on ways to improve their mood, improve their sleep, improve their appetite, improve their ability to care for themselves and complete ADLs. We would want to make sure that we're developing a therapeutic relationship. And we may prescribe medications, although medications are less commonly used in childhood mood disorders than in adults. For depression, we can prescribe them with an antidepressants. We do find that SSRIs are generally not as effective in children as they are in adults, so they may be prescribed another form of antidepressant. We can also prescribe antipsychotics if needed, and again, this is going to be at a much lower level than what we would see in adulthood. Then, lastly, we have childhood schizophrenia. As I mentioned already, this is very highly correlated with autism spectrum disorders. The onset is often prior to the age of 13, and children that develop schizophrenia have more severe symptoms as well as poorer outcomes than what we see in adult schizophrenia. As far as interventions go, we would prescribe medications for childhood schizophrenia, including antipsychotics and most likely anti anxiety medications and possibly antidepressants as well. As far as school interventions go, they're often going to be in a specialized class with a highly regulated structure and a lot of safety precautions. As far as family interventions go, we would want to provide respite care to help the family avoid being burnt out. We would also want to implement any interventions needed to keep family members safe. And we do find that alternative therapies work really well in childhood schizophrenia, including pet therapy and color therapy. And now moving on to mental health disorders of the older adult population. Most of these disorders are going to be related to cognition. So, cognition is the intellectual process of acquiring, using, or manipulating perceptions and information. Oftentimes, it elicits awareness of reality. It allows for acquisition of language. It allows for orientation to time and space. It allows for the ability to learn and problem solve. It is our basis for judgment, reason, attention, planning, and comprehension. It allows for concept formation, and it allows for understanding of and the use of symbols. It also works closely with the hippocampus to control memory. When we look at neurocognitive disorders or mental health disorders in the older adult population, most of them revolve around impaired cognition. So they cause a disruption in the cognitive process. The two types of neurocognitive disorders that we see are delirium and dementia. There are a lot of different types of dementia, and it is categorized as being cortical or subcortical. So, cortical dementias are disease processes that globally affect the cortex. And an example of a cortical form of dementia is Alzheimer's disorder. Our subcortical dementias are dysfunction or deterioration of the deep gray or white matter structures in the brain and brainstem. These often have more extensive symptoms, and they can affect arousal, attention, and motivation, as well as behavioral problems. So, when we look at delirium first, it's important to know that delirium is reversible. If we find the cause and remove the cause and treat it quickly, the patient will return to normal. If we don't recognize it and treat it properly, it can progress to dementia. With delirium, it develops very quickly, often over the course of hours to days, and it is considered a medical emergency that requires immediate attention. When we look at delirium, we know that it can impair consciousness. So the individual becomes less aware of their environment. They can lose the ability to focus and sustain and shift their attention. We see a lot of cognitive changes, which can include impaired memory, impaired orientation, and impaired language. It can impair their alertness, so they may become hyper alert as well as decreased alertness. It can also lead to apathetic behaviors, anxiety, disorientation, and development of hallucinations. It can develop in younger populations, but we do more commonly see it in the older adult population. A lot of times, delirium is misdiagnosed as dementia because it has very similar symptoms, and so treatment isn't properly provided in a timely manner. So, it's really important as nurses that we're recognizing delirium and advocating for our patients so that we can have quick treatment and quick removal of the cause. Risk factors for developing delirium include increased age, having previous brain damage, having dementia, being sensory overloaded or underloaded, being immobile, having sleep deprivation, having psychological stress, receiving surgery, or being hospitalized. We also see that development of delirium is very common with certain infections, such as a urinary tract infection. Delirium can also be caused by certain medications, fluid and electrolyte imbalances, metabolic changes, hypoxia or ischemia, and alcohol or substance withdrawal. So, when we're assessing our patients with delirium, our goal is to eliminate or correct the underlying cause, to treat the symptoms and provide supportive measures, and resolve any confusion that occurs, especially because the confusion also often leads to impulsive and dangerous behaviors. So, as far as treatment goes, we are wanting to promote our patients' safety first and foremost. So, we're going to assess any medications and stop any that are causing delirium. We would want to do their vital signs every 2 hours. And we want to be aware that they may need restraints if they become assaultive, self injurious, or interfere with medical devices. As far as other safety interventions go, we would want to ensure that their bed is low, that their side rails are up, that we're providing proper fall prevention, and that we're providing them with careful supervision. So, we're going to want to make sure that their room is close to a nursing station. They may need one to one observation or more frequent rounding. As far as behavior changes go, they're generally rapid and acute, and it can cause restlessness and agitation, or they can be lethargic and slow to respond. Our health assessment is looking at the onset, duration, range, and intensity of symptoms. We would assess for any recent illnesses. We would assess for a history of dementia or depression. We would want to assess for pain, sleep changes, or changes to the ADLs. And our interventions for any health related behaviors is to provide them with fluids and electrolytes, encourage a balanced nutrition. So we may have to assist them with feedings. And we also want to be aware that during delirium, they may become an aspiration risk if they weren't before. So we would want to make sure that we're providing nutrition accordingly. We would also want to monitor for any development of ulcers if they are immobile. As far as medications go, we want to assess for any over the counter medications that might interfere with their prescriptions. Common medications that induce delirium include cold medications, anticholinergic medications, anticonvulsants, anti inflammatory, anti Parkinson agents, antibiotics, flagyl, and analgesics. Our interventions for medication-based therapy is we may provide them with antipsychotics if they're hallucinating or delusions are present, but we want to be aware that a lot of patients have adverse reactions to Haldol, so we try not to use that as often with delirium. If we provide them with benzodiazepines, we want to make sure that it's a smaller dose, because what happens is their liver and kidneys have a harder time metabolizing medications. So if we give them a normal dose or too high of a dose, they can easily overdose on the medications. And we also want to assess if their delirium is related to withdrawal. If they are receiving benzodiazepines, we would also want to measure any level of sedation that they have. As far as mental status go, they can have fluctuations in consciousness. They can have difficulty sustaining and shifting attention, and they can also have memory impairments. So our interventions for that would be to Make sure that they have a clock that they can see, maybe having reminders, labeling where the bathroom's at, providing them with familiar objects or family members so that they have better orientation. We do find that family presence is very helpful to patients with delirium. It can help calm them and reassure them, but it also helps with orientation. As far as the emotional state goes, our patients with delirium may be scared and fearful, so we would want to encourage expression of their fears and any discomfort. They may be overstimulated by their environment, so we would want to limit any stimulation, dim the lights to a level that's still safe, maybe provide them with calming music or limit the sound. We would also want to provide a safe and therapeutic environment, um, providing them with easy to read calendars and clocks, using frequent verbal reorientation, and assess for any sensory defects. So if they have poor vision, we would want to make sure that we have their glasses for them. Or if they're hard of hearing, we would want to assess to see if they have any hearing aids and make sure that those are working properly. And then we have our dementias. As I mentioned earlier, there's both cortical and non-cortical or subcortical dementia types. These are most commonly things like Alzheimer's, vascular neurocognitive disorders, Parkinson-induced, or Huntington's-induced. To start off, we'll talk about Alzheimer's. So Alzheimer's is a degenerative, progressive neuropsychiatric disorder that is symbolized with cognitive impairments, emotional and behavioral changes, physical function decline, and eventual death. Typically, the onset is after the age of 65, but there is early onset Alzheimer's, which develops between the ages of 35 and 65. When someone has early onset Alzheimer's, it's often more rapid progression and more severe symptoms. Alzheimer's does develop through different stages. Mild Alzheimer's it is symbolized with loss of memory, language difficulty, mood swings, personality changes, and diminished judgment and apathy. Moderate dementia includes inability to retain information, behavioral and personality changes, increased long term memory loss, increased wandering, increased agitation and aggression, increased confusion, and more assistance with ADLs. Severe Alzheimer's includes all of that plus possible gait and motor disturbances. They may be bedridden and unable to perform their ADLs. They are often incontinent and often require long term care or placement in a facility. Diagnosis of Alzheimer's disease can only be done through autopsies, but generally we can assume Alzheimer's disease when there's cognitive decline from a previous level of functioning in more than one cognitive domain, and if there's a family history. So with Alzheimer's disease, we do see deficits in independence as they become unable to perform their ADLs. They can have aphasia, which is inability to express things verbally. They can have apraxia, which is the impaired ability to perform executive motor activities. They can have agnosia, which is the failure to recognize objects, as well as disturbances in executive functioning. So they may lack the ability to think abstractly, to plan and initiate things, to sequence and order things, to monitor, and to stop complex behaviors. With the mild cognitive impairments, we do see a decline in categories of cognition that don't affect activities of daily living as well. For the epidemiology, it does affect women more so than men by 2/3. Like I said, there is a strong genetic link, and it's suspected to be an autosomal dominant behavior or disorder. And we do see that it is more common in African Americans as well as Hispanic Americans. The etiology, as I mentioned, is the genetic component. And the way that Alzheimer's develops is the brain atrophies, and that could be due to multiple different processes. So the different processes that cause death of brain tissue include development of beta amyloid plaques. And these are proteins that clump together in the brain and they destroy our cholinergic neurons. So they interfere with the process of storing memories. We also see neurofibrillary tangles, and these are abnormally twisted proteins that thread throughout brain cells and cause brain cell death. The proteins contain tau, which is usually a supportive stabilizing structure that allows the transportation of cells, but when that's limited, it causes that cell death. Um, we also see decreased levels of acetylcholine, and this can impair cognitive functioning and memory. And often it's decreased because neurotransmission of acetylcholine is reduced. So the neurons are lost and unable to produce the level of acetylcholine that we need. We do also see that there are deficits in norepinephrine and serotonin. So there's a lot of studies that have been coming out that talk about how providing older adults with a low level antidepressant can have very protective factors in prevention of development of Alzheimer's disease because there are more neurotransmitters than just that acetylcholine that are involved in the development of Alzheimer's. Although acetylcholine is the main neurotransmitter that we see decreased levels of. It can also be caused by free radicals and oxidative stress. So the free radicals in the brain increase, which causes the oxidative stress that damages cellular molecules such as proteins, lipids, and nucleic acids. This changes chromatin, which can alter the DNA and protein production, which ultimately is the result of dysfunctional gene expression. And then lastly, inflammation in the brain can cause small blood vessel changes and therefore brain cell death. So, when we're assessing someone with Alzheimer's disease, we want to assess their movement. How is their gait? Do they have any contractures? How's their activity level? Do they have any pain? Any seizure activities? Are they feeling more withdrawn from their normal activities? Are they wandering more frequently? We would assess their sensory status. Do they have any sensory aid needs, such as hearing needs or vision needs? Do they have dysphagia and require accommodation for that? We would want to assess their memory. Do they have any alterations in their CNS, which could impair their ability to collect and process environmental information? We'd want to assess their sleep patterns. Do they have frequent daytime napping and nighttime wakefulness? Are they restless during their sleep? Are they irritable? How is their nutrition? Do they have any appetite? Are they having any difficulty eating or swallowing? Do they have hyperoral nutrition, which is where they chew and eat anything possible and sometimes non food substances? With pain, it can be difficult to assess, especially if that patient's nonverbal. So, we would want to use nonverbal pain assessment scales as well. And this can include any sensitivity to touch. Behavioral changes can be indicating pain. Are they more lethargic? Do they have anxiety or restlessness? Do they have any physical signs like tachycardia, tachypnea, or pyrexia? Do they have hypervocalization, restlessness, agitation? All these things are going to be included in your physical assessment for your patients with Alzheimer's disease. We're also going to assess their psychosocial health or physiological health. So, do they have any apathy, any lack of spontaneity or passive behaviors? Do they have increased irritability, sarcasm, or self preoccupation? Do they have intolerance or lack of concern for others? There are different scales that we can assess their cognitive functioning, such as the mini mental status exam, which is accommodated for patients with Alzheimer's disease, or there's the AD8 scale, which contains 8 questions for family to rate changes in memory, problem solving, orientation, and ADLs. As far as memory goes, we would assess for any forgetfulness or repetitiveness in conversation. Do they often misplace objects and miss meetings or when things are due? Do they often forget what they're doing? How is their insight? Do they confabulate conversation? So, what this means is when they're having a conversation and they don't remember something, they'll fill in the blanks of what they don't remember with falsified information to try and make it seem like they have better cognition and better memory than they actually do. Do they have short term recall? So remember, we would assess this by providing them with 3 words and having them recall it at different intervals, like 5 or 10 minutes after providing them with those words. We would also want to assess for any long term memory. And remember, when we assess the long term memory, we want to use questions that are both culturally and age related in relevance. For language, do they have agnosia, which is difficulty finding the right word in a sentence or inability to name an object? Do they have any visual spatial impairments? So we would want to assess their sensory and more motor coordination. They may have more difficulty with drawing, cooking, balancing their checkbook, things like that. We would assess for any executive functioning, any psychosis, delusions, or illusions. The most common delusion that we see is they fear someone is an imposter. They may also have beliefs of infidelity. They may have delusions that people are trying to hurt them or steal their belongings. They may believe that other people are living in their homes. They may believe that people on television are real and not actors. And the most common hallucinations we see with Alzheimer's disease are visual hallucinations. We'd also want to assess for any mood changes, especially depression. We would also assess for any anxiety, guilt, feelings of worthlessness, frequent crying, insomnia, weight loss, or suicidal ideation. We want to assess for any catastrophic reactions, which are overreactions or extreme anxiety to everyday situations. So they may become verbally or physically aggressive, have emotional outbursts, compulsive or repetitive behaviors, or they may be cognitively or socially inaccessible. They can often have fatigue and exhaustion from overwhelming sensory stimuli and physical stressors as well. We, as far as behavioral changes go, we want to assess for any apathy or withdrawn behaviors. Like I mentioned earlier, this is a more moderate to late stage Alzheimer's symptom. We'd assess for any restlessness, agitation, or aggression. If they have any aberrant motor behaviors, such as fidgeting, picking at their clothes, wringing their hands, having hypervocalization, such as like screams, curses, moans, do they have any wandering behaviors? We would want to make sure that we're assessing for any underlying conditions such as delirium, dehydration, any medications that cause increased symptoms, pain, or infection. We'd want to assess for any disinhibition, which is acting on thoughts or feelings without using appropriate social judgment. So they may use more offensive language, they may be more sexually preoccupied, they may have poor judgment on proper clothing, things like that, that we would want to assess for. And then lastly, we want to assess the family response to their family member having Alzheimer's disease. As far as interventions go, for medications, the purpose is to prevent further decay of cognitive functioning. We can use medications to treat any behavioral or psychological disturbances. Rule of thumb is to start low and go slow. So just like the benzodiazepines that we talked about earlier, in the older adult population, they have a harder time metabolizing medications. So we do lower doses so that we prevent any increased side effects or any overdoses on medications. Typically, we'll provide them with an ACE inhibitor. These work better when used earlier because they aim to prevent decreased acetylcholine. So they prevent acetylcholine esterase from breaking down acetylcholine and preventing that memory decay. Another medication that we can use is Namenda. Again, there is a lot of controversy over whether or not it's appropriate to use this because it has limited effectiveness once diagnosed with Alzheimer's disease, but it can slow down cognitive delays. We want to try and avoid antipsychotics if possible, but sometimes they are necessary. And benzodiazepines should only be used on a short-term basis. As far as sensory assistance goes, we can provide them with glasses, hearing aids, larger print, and things like that. For self-care, we want to help them maintain as much independence as possible and encourage good oral hygiene, especially because a lot of the medications used for Alzheimer's disease can cause dry mouth. So we can provide them with hard candies, chewing gums, glycerol mouthwash, and artificial saliva to help prevent that dry mouth and subsequent development of thrush or dental decays. Another thing to be aware of as far as self care goes is that bathing time is a high time for agitation and aggression. So, if you need to help them with their bathing needs and their hygiene needs, sometimes it's beneficial to have more than one person to help calm that patient down and prevent any safety impairments from the agitation or aggression. For the bowel and bladder functioning, they can have a high level of incontinence, and this may be due to the inability to remember where the bathroom is or to communicate that they need to use the bathroom. So, we do recommend that assessment of urinary needs every 2 hours when we go in to do our turns, making sure that we're assessing if they need to get on the bedpan or get up to go to the bathroom. We can also label the bathroom door so that they don't get confused on where it's at. Um, if needed, we can use briefs, but if we are using briefs, we would want to make sure that we're assessing and changing those frequently so that they don't develop any skin breakdown from sitting in the wetness. As far as sleep interventions go, we would want to use any sleep hygiene techniques that we've talked about in all the other lectures. We would want to promote activity and exercise that matches the culture, functional ability, and interests of the patient. We want to prevent any excessive stress, both physically and emotionally. So, we would want to encourage activities that are not too strenuous. A very popular activity in patients with Alzheimer's disorder is chair yoga. As far as nutrition interventions go, we want to accommodate any swallowing difficulties and assess and monitor intake and output. For pain management, oral morphine is commonly used, and with that, they're high risk for constipation. So, we would want to make sure we're assessing that and providing any stool softeners if needed. And with pain management, we always want to make sure we're encouraging non pharmacological or alternative therapies. For relaxation techniques, we want to always approach our patient in a calm, confident, and unhurried manner, maintain a soothing, quiet environment, and use of therapeutic touch. For memory and orientation, we want to maintain their memory function as much as possible. We want to encourage them to tell stories of their younger years. And we can use visual cues to help them maintain their memory. So, such things as posting pictures around their room, using reminders of their likes and interests, using sense and other sensory stimulation to promote memory retrieval. With this, we'll often have reminiscence groups, and those are groups where the patients will all get together and you can play music from their teen years and they can talk about how that makes them feel. We can use things where they tell stories about their life and their childhood and things like that. Um, we also want to make sure that we're orienting our patient to the time of day and location. As far as language goes, they often fill in the blanks with confabulation if they can't remember. So we can help them by prompting the things they can't remember or the words that they're looking for. And this helps prevent them from getting overwhelmed or angry if they can't think of what they're trying to say. As far as visual spatial functioning assistance goes, we can use assistive silverware if they have poor motor movements and coordination. We would also want to make sure that they're dressing in sequence and they put their clothing on the correct way. So we would want to lay out their clothing in a way that's going to make it easier for them to properly put their clothes on. For managing psychosis, we want to educate them on transitions because they can have suspicion when daily changes occur. Sometimes, if they have a lot of distress when triggered by their own reflection, we could remove the mirrors or any artwork that may perpetuate their delusions. And if our patient does have psychosis with their Alzheimer's disorder, we would want them to be in close proximity to the nurse if they're hospitalized. For managing stress and anxiety, we want to lower any demands and simplify their routines. We also want to eliminate large number of choices. So instead of saying, where do you want to eat? You could say something like, do you want to go to Olive Garden or Applebee's to eat? Um, as far as managing their catastrophic reactions, we want to reassure them of their safety, give them information slowly, clearly, and simply, and make sure that we're empathizing with them and understanding their fears. If they have wandering behaviors, we want to make sure that we have adequate staffing on the unit to help monitor with that. Some units will have electronically controlled exits so that the patients can't leave the exit. We can join them on their walk and interrupt their wandering and redirect them back to where they need to go. And then using visual cues helps to reduce wandering as well. So having signs on their door that say, this is your room, this is the bathroom, this is, the nutrition room, things like that. For managing any agitated behaviors, we want to approach them in a calm, unhurried, and undemanding approach, and manage any aberrant behaviors by trying to understand the meaning and the trigger for their outburst. For reducing inhibition, we would want to redirect any undressing or inappropriate touching or behaviors. For safety interventions, we might supervise their cooking, cleaning, or household tasks. Sometimes they'll also be enrolled in an adult daycare. So, this is similar to child daycare, but what happens is if family is able to provide a supportive environment for them at home, but they work during the day, they can drop them off at these day centers where they engage in different activities and trips, and then the family can pick them up when they're done with work. And this is really effective in preventing them from going to a nursing home or a long term care facility if that's not the patient's wishes. As far as milieu management goes, we'd want to reduce any overstimulating activities. For social activities, we'd want to reinforce social gestures, eye contact, smiling, greeting, and farewells. We want to encourage a sense of competency and self esteem. We can encourage humor and play. Again, with the social activities, that reminiscence therapy is effective. We can also use pet therapy, and we have found that providing the patient with a baby doll or a stuffed animal is very effective in helping them keep calm and safe. As far as family interventions go, we'd want to assess the needs of the family and provide respite care if needed. We would want to address any feelings of isolation, frustration, or being trapped. If they are living at home and we do home visits, we want to encourage independence as much as we can while allowing the highest cognitive, physical, emotional, and spiritual and social functioning. We do know that about 80% of individuals with Alzheimer's disease either have home health care or support from their family and friends, and 60 to 70% still live at home. So that about wraps it up for Alzheimer's disease. So now moving on to the dementias induced by other illnesses. A lot of times these dementias will have similar symptoms as Alzheimer's disorder and similar interventions and treatments. So one way that dementia can develop is through Huntington's disease. So Huntington's disease is an autosomal dominant disorder with an onset between the age of 30 and 50. It's characterized by coriform movements, which you can see in the picture here. It's kind of like a dancy motor tic. Um, and they can also have disruptions in their cognitive functioning. Huntington's disease is a form of frontal dementia, so we do see changes in both their behavior and personalities. Another form of dementia is through Parkinson's disease. About 75% of individuals with Parkinson's disease will also develop dementia like symptoms. We do find that those anticholinergic medications can improve cognitive impairments in Parkinson's disease. Then we have our vascular and neurocognitive disorders. So, this is a form of dementia where a decline in thinking is caused by conditions that reduce blood flow to the brain. So, it can be formed through blood clots, a TIA, fatty deposits that cause an obstruction, and through other forms of strokes. This does affect men more than women, and the onset is often very sudden. When someone develops vascular neurocognitive dementia, we would want to make sure that we're getting them assessed for any signs of a stroke. Then we have our frontal temporal neurocognitive disorders. So these are dementias that are more progressive and they do involve both behavior and personality changes with language impairment. So what happens is they have atrophy of the brain tissue in their frontotemporal areas. So when you think about the function of the frontal lobe and when you think about the function of the temporal lobe, that's a good way to understand the different symptoms that we see with this. So we do see things like those personality changes, apathy and disinhibition, difficulty socializing, difficulty with self care, inability to be socially appropriate. So they have limited insight, limited judgment, impulsivity, and things like that. Then we have our other neurocognitive dementias. This can be due to Lewy bodies, which is a progressive cognitive decline with visual hallucinations, rapid eye movement sleep disorders, and spontaneous Parkinson's like characteristics. The cognitive symptoms often develop before the motor symptoms and they can resemble delirium. Our patients with Lewy body dementia are a high fall risk. They often have syncope and transient episodes of consciousness. They often have hypotension as well, so we would want to make sure that we're assessing their vital signs thoroughly and treating any hypotension. They often have increased urinary incontinence, and there's a lot of belief that this is a genetic cause. Another form of dementia is through Prions disease, which is a small infectious particle with abnormally folded proteins that cause progressive neurodegeneration. It can also develop from spongiform encephalopathies, mad cow disease, and botulism. The symptoms often fluctuate and include things like fever, difficulty swallowing, incontinence, tremors, seizures, and sensitivity to touch and environment. Transition of the prion is often between people and animals, and people to people transition is quite rare. Then you can develop dementia through a traumatic brain injury. A lot of times, traumatic brain injuries affect the frontal lobe. So, we do typically see changes in impulsivity, in judgment. We can see behavior and personality changes to more increased violent behaviors and other things that we see with damage to the frontal lobe. And then, lastly, dementia can also be caused due to substance abuse and brain damage through excessive use of alcohol and other substances. Another thing that I just want to mention with adult mental health disorders and older adult mental health disorders is that we do see increased depressive symptoms in our older adult population. We talked about this quite extensively when we talked about depression, but our patients are at increased risk of depression and suicidal behaviors in the older adult population.